Okay, so my chore was to talk about pelvic pain from the point of view of ultrasound. And I must say that ultrasound is very commonly used after an MRI to sort out what they couldn't figure out by MRI. And that makes me think oftentimes that MRI should be skipped and we should go straight to ultrasound. I do many scans daily for gynecologic issues. And I think I recommend an MRI maybe once a year, maybe not even then. And with 3D, I think the need for MRI has really dwindled a huge amount. Before 3D, I would be absolutely in agreement that the coronal view of the uterus and the pelvic floor and all of these different things would be beneficial, better seen by MRI. But now with 3D ultrasound, I really don't think that's any longer the case. I call it the curse of pelvic pain because there are so many patients that have pelvic pain, that live with chronic pelvic pain, and for whom we never find an answer. Pelvic pain accounts for 10% of referrals to a gynecologist and more than 40% of diagnostic laparoscopies. Many of patients live with chronic pelvic pain their whole life that never get diagnosed. So these are very eager patients to get a diagnosis and to come in for whatever we need to do. Now, the advantage of an ultrasound is that we can talk to the patient. We actually go in as practitioners and do a physical exam at the same time. So we can ask the patient whether the pain is chronic or acute, whether it's focal or diffuse. Does it come cyclically, or is it there all the time? Is it sharp or dull? You obviously must know whether the patient's had any prior surgery or history. You absolutely have to know the menopausal status and their hormonal status, whether she's on any hormone replacement therapy or birth control pills. And of course, could she be pregnant? So during the scan, you have a great opportunity to actually do a physical exam. And even though I am a radiologist, and I know that many radiologists have the reputation of sitting in a dark room, I do get out of the dark room and I examine every single one of these patients myself because I want to know how tender the patient is, whether the area of tenderness is focal. I definitely want to know whether the organs slide past each other. And so I do push deliberately on the organs to see if they actually slide past each other. So let's start talking about the uterus. These are some of the findings that we might see in a patient with pelvic pain: adenomyosis, degenerating fibroids, prolapsing fibroids, and certainly abnormally placed IUD, which is now becoming more and more prevalent out there as IUDs are placed more often. So adenomyosis is defined as the invasion of endometrial glands into the myometrium. And it's quite common, although how common it is controversial because its frequency is reported anywhere between 5 and 70% due to different criteria that we have. But it is probably quite common, and the symptoms tend to be dysmenorrhea, abnormal bleeding, and uterine enlargement. The appearance tends to be very mottled, inhomogeneous, with small little cystic areas, subendometrial cystic areas, and an indistinct endometrial stripe or endometrial echo. I don't know if Steve is in the room. Steve Goldstein doesn't like me to use the word stripe. And an asymmetric appearance of where the endometrial echo is. So it's more to one side or more anterior. It's not in the middle of the uterus. So let's look at a couple of examples, and maybe we should put the lights down a little bit to see these a little better, if there's any way to put the lights down just a tad. So here is a uterus that has a pretty severe adenomyosis, and yeah, that's much better, thank you. Where you can see that I've put the calipers on the endometrial echo here, but it's very hard to define. And sometimes you can't even see it at all. I've tried to put calipers here thinking this might be a fibroid, but there are really no boundaries here. What there are these little subendometrial echoes here. Now here's a typical endometrial echo which has moved over to one side because one side of the uterine wall is thicker than the other side. And that's typical of adenomyosis, and also typical is the lack of a distinct endometrial echo that you can actually measure there. Now, going on to fibroids, obviously they are very, very common, and they most of the time do not cause pain, but they rather cause bleeding. And the position of the fibroid, or certainly the degeneration of the fibroid, may make them quite symptomatic. And of course, the size of the fibroid may cause hydronephrosis and other pressure on internal organs. Now, the many faces of degenerating fibroids, if you know what degenerating fibroids look like, you can see that there are solid areas within a cystic sea of fluid here, and sometimes they can form a thick rind. In this case, there is a echogenic sort of rind around the cystic area. This is typical, as is this, of degenerating fibroid. These are much less typical. These two are the same case. And I think here the trick is to find that it is in continuity with the uterus and to find a normal ovary along with it. Now, this was something that was tricky, and perhaps you might call this an endometrioma, because it certainly looks like it has low-level echoes throughout. But the fact that we found a normal ovary on that side, you can see the normal ovary right there, and we were able to peel this off the ovary by pressing on it. We were able to determine that this is probably degenerating fibroid, which it actually was. So pushing around on the organs is very important, as I'll show you again more later as we go along. As more and more IUDs are being put in, there are more and more patients coming in with pelvic pain because of a positioning of the IUD. Now let me take a moment to say that 3D ultrasound now allows ultrasound to generate these images of the coronal view of the uterus, which is so useful for uterine shape abnormalities, positioning of IUDs, positioning of fibroids within the uterine cavity, all sorts of things. I didn't bring any images of uterine shape abnormalities, Mullerian duct abnormalities, because they don't really oftentimes result in pelvic pain, but I think all of you know how good 3D ultrasound is in determining Mullerian duct abnormalities. But really, the beauty of 3D ultrasound is the ability to show the uterus in the same orientation as a Netter diagram. There's a reason why Netter chose to demonstrate the uterus in this coronal view, because it is the best way to evaluate the uterus, the cavity, the outline of the outside of the uterus, the inside of the uterus, and so forth. And now with 3D ultrasound, we can actually demonstrate that very same view, and anything that's in the uterus, including the IUD and the string, we can actually see this way. So where is the IUD? Well, in 2D, obviously, it's in the uterus here, but we don't see the arms very well, and the arms are usually the problem. And here, this IUD is low, but in fact, the arms are embedded in the myometrium on both sides. And these patients have quite a high incidence of pain and bleeding. Here's another one, a low-lying IUD within the uterus. Again, you can see the shaft pretty well, but the arms are much better seen with 3D ultrasound. It's really not even an effort to get this coronal image right in the middle of the uterus and show that that IUD is crooked and trying to come out. So we actually looked at, in a recent study, the frequency of IUDs being embedded and whether they could be responsible for pelvic pain and abnormal bleeding. And we looked at 167 consecutive patients, and it turns out that 16% of them had IUDs that were embedded. And these are all comers. Everybody that had an IUD was looked at this way. We do 3D ultrasounds on all of these patients. And we found that 16% were embedded, and all the IUDs that were considered low in the uterus were embedded. And there's, I think, an obvious reason for that is that the lower uterine segment does not accommodate the size of an open IUD, because that part of the cavity is very narrow. So if the IUD is going to open comfortably, it's going to have to be at the very top of the cavity. And so when we looked at the incidence of pain and bleeding, we found that those that had embedded IUDs came in for an incidence of 39% for pain, 35% for bleeding. So 70% of the time they came in for either pain or bleeding, compared to those that were not embedded, 15, 19%, and overall 34%, which was statistically significant. So this is a cause of pelvic pain, one that we can identify easily using 3D ultrasound. And now the moraines are particularly hard to see because they're more lucent by ultrasound. They're not quite as echogenic. So we can use the shadow of the morena as I do here. So here is my little box of 3D, my window, and really what I'm showing here is not the IUD, it's the shadow of the IUD that's taken down here somewhere. But you can actually back into where the IUD is following that shadow. And here's a morena, which is the one that's so hard to see, but the shadow is much easier to see. So once you see a shadow, and you see it's definitely not in the right place, it's upside down and backwards sort of, but you can back into the actual IUD itself, which is much harder to see, but now we can back into it showing where that IUD is located. So here this IUD was very hard to see. You could see that the shaft was somewhere in the middle, but in fact this IUD looks like an anchor. It's completely upside down, which sometimes makes you wonder how they were put in, how it could actually turn all the way around this way. And these patients all had some pain. Now, you can see the arms of the IUD, sure. You can see the shaft of the IUD, and you can see the arms of the IUD. Trouble is you can't see the uterine cavity with 2D ultrasound, and that's why you need 3D, because sure you can see the IUD, but you can't see where it is within the uterus without seeing it in 3D, because there you have enough contrast so that you can see the IUD and you can also see the cavity so that you can make sense of where it is inside the uterus. So all of the reasons to get an MRI, to get a view of the coronal view of the uterus, has been now solved with 3D ultrasound and the symbol manipulation. Here's another low IUD. The arms are seen quite well, but they are not in the right place. And this, the 3D also gives you that large field of view that Genevieve was talking about, where in MRI you see a much larger field of view. And sure enough, 3D ultrasound gives you also that much larger field of view, much larger than you can do in 2D ultrasound. Now here's a patient that came in for pelvic pain, and looking at this transabdominal scan, I thought she had a little fibroid, calcified fibroid here. We didn't know whether or not she had an IUD. It wasn't in the requisition. So transvaginally, here is the region of the fibroid, and what do we have here? We have a linear thing that's sort of traversing the front of the uterus, and this is a 3D showing an IUD, which now we knew she had, poking out the front here with a little sort of pucker in the serosal surface of this IUD. And if you look at this clip, you can see the IUD is right here, and the bowel is sort of swirling around the IUD. This was a scary picture. So the question begs as to whether the uterus is actually too small for some of these IUDs, because why are there so many of them that are misplaced? Here's a nice IUD. It looks like it's centrally located, but in the 3D ultrasound, you'll see that the IUD just never got deployed because these uteri are really small. And so the question is are many of these uteri too small to accommodate the size of the IUD? And believe it or not, IUDs are only one size. They claim one size fits all, and that's not true because one size does not fit all. And if you look at the morenas and the paragards are both 32 millimeters in size, period. End of discussion. That there is no small size for patients who have small uteri. And yet with the embedded IUDs in our study, less than 14% of them had uteri that were that wide. So no wonder they could not be placed properly. So I don't know who decided that the IUD should be 32 millimeters across. We actually looked at that problem and found that if you measure the width of the endometrial cavity at the top there, that it makes a big difference if the patient has been previously pregnant. That if the patient is a nulliparous, that the average width of the endometrial cavity is actually below 32 millimeters. And I'll show you, I think I have some data on that, which I'll show you in a minute, but this is how we measure it. And this IUD fits in because this cavity is wide enough. But this cavity is not wide enough, hence the IUD is crooked. I don't have the data to show you at this point, but I'll tell you that the normal width of an endometrial cavity in a nulliparous patient is 25 millimeters, compared to 32 to 34 millimeters in patients who've had one or more pregnancies. So hopefully there will be a different size IUD that will appear for that reason. Now going on to the adnexa, this is a list of reasons why the patient may have pelvic pain. And we'll go through some of these in detail, and some of these are the same ones that Genevieve showed in the prior talk. But let's see what we can glean from what we can see. Now, the hemorrhagic cyst is pretty typical in appearance by ultrasound. The typical appearance is shown down here. It's a cyst. It's got some mesh-like clot that has a pretty straight line. It actually is pulling away, not growing into the cyst. And here again, this is solid. If you turn on the color, there won't be any color in it. And this is pulling away from the center. So it's not really growing in. It's a bit very different from a nodule, which is really growing inwards. Here again, this is the mesh-like, very typical hemorrhagic cyst. This one may be less typical because it's pointing in, but if you jiggle this, it will jiggle like jelly. And if you turn on color, there won't be any color in it, and that's how you can make the diagnosis that this is a clot. I think that if you were just to look at this picture and not have examined the patient, it would be difficult to make the diagnosis of this as a hemorrhagic cyst. But if you jiggle it and it jiggles, if you turn on color and there's no color in it, I think you can easily make that diagnosis. Now, a torsed ovary has a very typical appearance by ultrasound. This is a young girl, a college girl, who came in with severe pelvic pain about a week before this, and she'd gone to the infirmary and she'd had an ultrasound, and they told her that she had a big ovarian tumor and she probably had ovarian cancer. And the next morning, I had her and her parents in my office in an absolute panic, and this was the ovary. It's a very typical enlarged, globular, really pathognomonic appearance for a torsed ovary. And once you decide that this looks like a torsed ovary, then you can easily go looking for the smoking gun, if you will, which is the twisted pedicle, and you can see the whirlpool sign here, and sometimes you can see the thickening of the pedicle in this case. Now, endometriosis is an area of great interest of mine recently, because it is something that for a long time ultrasound really could not help with. And I think we all know that if you see a mass like this that has low-level echoes and maybe slightly irregular walls but not a whole lot of color, this is typical of an endometrioma. And because endometriomas are sticky and there's a lot of adhesions, you often have an associated hydrosalpinx, which I would almost expect now when you have endometriomas. And these are quite common, but what you don't expect is the unusual appearances and localizations of other areas of endometriosis. So here is a luteinized or decidualized endometrioma, which occurs in pregnancy and which can look very much like a borderline ovarian cancer. These things do light up with color, interestingly enough. But if the patient is pregnant, we follow them over the course of a month and just make sure the area is stable. But when the patient is not pregnant and having pelvic pain, and say that you've looked at the uterus and both ovaries and they look fine, you're not done yet. You're not anywhere near done. That's really just the beginning, because then you look in the cul-de-sac and you look for these little nodules that are right back along the back of the cervix, along the uterosacral ligament. There's a whole lot of things to see back there. First of all, you can see endometriosis in the floor of the bladder. Usually that's just a fusiform wall enlargement of the bladder. That's quite typical. But when I'm talking about these little implants, are these little tiny guys right there. Here's some fluid in the cul-de-sac. Now, if you look carefully, you'll see that the fluid in the cul-de-sac should actually be closely applied to the back of the cervix. But here in the vaginal rectal septum, right here is an implant that is very painful. And you can walk around with the vaginal probe back there and sort of test the pain. And the patient will say, oh, yeah, that's exactly the spot. And that's where you usually find. So it's sort of a pain guided, if you will, exam. Very gently, you sort of poke around to find the place. And we are finding now more and more of these patients that have implants of endometriosis in the bowel wall. And they reside right here in the rectosigmoid, which is usually right along the back of the uterus. And if you look back there, you'll find these areas right here in the bowel wall. Here's the lumen of the bowel. Here's another one, very long segment, the lumen of the bowel right here. And here's another little one. But you can actually look at this in 3D and do the tomographic cuts just like an MR or a CT. I can make an ultrasound look like an MR and a CT actually this way. And you can see that these implants are right up in the wall of the bowel and right up against the back of the cervix. As it turns out, a lot of this work is being done outside the United States right now. And this shows that there is a very high sensitivity and specificity for detecting bowel endometriosis. And there is quite a high prevalence of bowel endometriosis in patients with endometriosis, and we are now able to find them with quite a lot of accuracy. And just to show you another example, this is the cul-de-sac of somebody. And this is usually right up against the transducer, so you have to use your highest frequency your transducer can do. And you have these little implants right here up against the rectosigmoid that itself has nodular enlargements in the wall, which you can see here and here. And it typically forms these little digital protrusions, which are typical of implants of endometriosis. And if you push this, normally the back of the uterus would slide right by the bowel, and there might be a little bit of free fluid around. But here, this is not sliding at all. It's adherent to the back here, and this is the top of the rectovaginal septum, and everything is just matted down in this patient who has endometriosis and pelvic pain. And what she does have is a normal uterus and ovaries. So you really owe it to these patients to look further. Going on to other causes of pain in the adnexa, hydrosalpinx, adhesions, we're going to put all these together in one lump and look at the adnexa. Here's a patient that had pelvic pain, and this was her tube. And as I poked around, this is where she was tender. So we made the diagnosis of salpingitis, which is what she had at laparoscopy. So you can have a pain-guided exam that really will take you right to the source. If you see fluid in the adnexa, you might not be able to make a definitive diagnosis of hydrosalpinx unless you use 3D, but in some particular plane, you will be able to show that it is a tube and not a series of cysts. Is this an ovarian cyst? Well, you can take a 3D and use the inverse mode, which is basically taking the volume, making everything that's cystic opaque in the volume, and then having all the solid areas melt away, and then you have a cast of the tube. And so we're able to do this. Here are a couple of other cases. This is a tube right here, and this is a tube with a big end right there. So now we can really easily make the diagnosis of hydrosalpinx without really having to struggle or without having to give a differential diagnosis. Now here is the same type of peritoneal inclusion cyst that Genevieve showed, with these thin septations. The thing, it insinuates itself to the sort of floor of the pelvis. And this little thing here, if you wonder what this is just the edge of an ovary, where in fact the ovary was right here and it was embedded. If you look carefully, you will find the ovary, because the ovary is usually embedded in the mesh of this peritoneal inclusion cyst, and it is there, and it is recognizable. Now this one, I was led off course here because I actually call this a multiseptate cyst, and interestingly enough, this was a peritoneal inclusion cyst. So sometimes you can be led down the wrong path, but this was actually a surprise. Here's a big tube that looks very swollen, has some echogenic material in it. This patient was very, very sick, and this is clearly PID, and with a lot of blood flow here, a very sick patient. Now this patient has one of two things. She either has PID or an ectopic pregnancy. That's really the differential. So either she's really sick or she's pregnant. And there's a real big difference clinically between those two things. So again, you can't read these in a vacuum. You have to know the background of why the patient is here. This is a TOA. Now here is an ectopic pregnancy. This is an empty uterus. This is a nice ovary right here. And here is the ectopic. Now you might think, well, what is the difference between an ectopic and a corpus luteum? And the difference is that the ectopic has a very echogenic rim. They both have a lot of blood flow, so blood flow doesn't work in my opinion. But this has a very echogenic rim, whereas the corpus luteum has a very echolucent rim. And that's how you can make the difference between them. You can also push between them, and you will find that they pull apart. And that's another way to help make the diagnosis. Now, we talked about MRI being helpful to determine where the pregnancy is and whether there's a Mullerian duct abnormality. And again, I didn't bring Mullerian duct abnormalities here, but I did bring this case that was sent to us as a second opinion for where is the pregnancy. Is it in the uterus? And it sure looks like it's in the uterus here. Here's the cavity. It's over to one side. But 3D is very helpful to see in the coronal view whether it's in the uterus. And the answer is it is not in the uterus. It is in the cornu. This is the cavity right here. There's an acute angle that is formed here because this thing is outside the uterine cavity. So 3D is incredibly helpful to locate where these pregnancies are. Here's a patient that came in for nuchal translucency. And as we were scanning her, she was complaining of some pain. We looked at the adnexa, and she had this big old sausage thing looking here. No color inside it. The color was all on the outside. And so we were suspicious that this was a lot of blood here inside the tube. And she went to the OR. This was a heterotopic pregnancy. Now, the pelvic floor. 3D has opened the pelvic floor up to ultrasound. And now we don't need an MRI for the pelvic floor. We can actually see, if we reconstruct the coronal view of the perineum, we can see the rectum, we can see the sphincter, we can see the urethra, we can see the vagina, which is sort of a smiley face right here. And when there are abnormalities like this patient came in for a perineal pain. This is an anterior sort of cystic mass. It looked like it was near the vagina. Couldn't tell what it was. Here's the bladder right here. We're looking down the vagina on the perineum. Here is the reconstructed view. This is the item right here. And the little dot is right here in the item of interest, which is right adjacent to the urethra. So you can see here that this is a urethral diverticulum. That's what the problem was. Here's another one. This was a Bartholin duct cyst, which is actually next to the rectum as opposed to being next to the urethra. So the last couple of minutes, I just want to talk briefly about non-gynecologic diseases that do occur in the pelvis. Stones, bowel issues, adhesions, all of that. And here's a patient that had a ureteral stone right here. You can see it nicely by ultrasound with the shadowing, and you can see the corresponding hydronephrosis that this patient had. This patient had Crohn's disease, and you can see the thickening of the bowel. This is not nodular like endometriosis. This is diffuse thickening. And of course, this is lymphoma, which is very, very different looking thickening of the bowel, very ugly, very edematous bowel. Now I'm going to end with this appendix. Sorry, this didn't quite make it all the way down here, but this was an interesting case. This is a young girl who was in college and presented to her infirmary for pelvic pain, and they did an MRI, or they did an ultrasound starting out, just a regular ultrasound that was read off-site, and decided that this was a hydrosalpinx. And so then they got an MRI and decided that maybe she had PID on the MRI. And so they gave her a course of antibiotics, and she came back and it looked a little better, and then she got off the antibiotics and it looks worse again. She had another MRI. It showed that it really hadn't gone away. She finally came to me for an ultrasound, and this was an appendix. So we use ultrasound as a problem-solving tool after an MRI or a CT scan because, in fact, it is a better tool for the pelvis. So in conclusion, pelvic pain is very common. It impairs the quality of life. 3D ultrasound has given us the opportunity to really cement ultrasound as the forefront diagnostic capability or diagnostic image technique to use for these patients. And without 3D, I think that wouldn't have been the case, but with 3D, we really have all of the capabilities. And the patients who cannot have transvaginal scans, we actually do transrectal scans, and we do it quite a bit now on virginal patients and older patients who can't tolerate the probe. And those that we help are among the most grateful of our patients, and they all just came in for an ultrasound. Thank you very much.